Hello everybody, my name is Kurt Scheeler. I'm one of the pediatric echosonographers here at Children's Hospital Colorado. Today I'm going to be presenting on how to scan pulmonary hypertension in the pediatric population. You're going to see a lot of relevant information in today's slides, such as formulas and tables. However, I'm not going to be going into great detail on those. I am going to be focusing on how to scan. If you are interested in this additional information, it may be possible to acquire a PDF of this presentation. I would contact our organization and inquire if this is possible. I have no relevant disclosures. Okay, echo goals. They are to determine the presence and severity of pulmonary hypertension. Normal cardiac pressures in children tend to increase with age. As such, a fractional relationship of pulmonary systolic pressures related to systemic systolic blood pressure creates a more accurate representation of pulmonary hypertension. So by example, in the adult world, we're all familiar with 120/80 as a normal. However, a healthy newborn systemic systolic pressure might be 60 to 80. So by example, if we look at this chart right here, a normal range in a child might actually be somewhere around a third or less of systemic blood pressure. Timing. It should also be noted that in utero and shortly after birth, pulmonary pressures are significantly higher due to normal developmental processes. These pressures tend to drop pretty rapidly over the first 24 hours of life and then gradually diminish over the next 1 to 3 months. So by example, what may appear to be mild to moderate hypertrophy in an adult may actually be considered normal in an infant for the first 2 to 3 months. Okay, this is a nifty chart that shows the different ranges that we use to grade pulmonary hypertension, which you can always refer back to if you'd like. All right, let's get into imaging. The first 4, a quick overview of the patient's pulmonary hypertension status. So this is a really great set of imaging. It gives both you and the physician a quick snapshot of what's going on with the patient. It's actually the first 4 images in our pulmonary hypertension protocol here at Children's. It's going to start with the subcostal coronal view with a slight anterior tilt, then parasternal long axis, parasternal short axis, and then finally apical floor with an RV focus. Okay, let's look at each of these a little closer. The first one here is the subcostal coronal view with a slight anterior tilt. What you want to do is get in there and angle up a little bit until you see this right ventricular free wall. This is a really great view for an overview. You can see things like right ventricular function, size, dilation, any possible hypertrophy, right atrial dilation, and any possible LV compression. This next slide, of course, is parasternal long. Here you can also look for things like RV size, dilation, function, hypertrophy, possible LV compression. Parasternal short, again, right here you have the right ventricle, so you can look for size, dilation, function, any possible hypertrophy. You can look for left ventricular compression. And then, of course, this is the septal flattening. This is the septum between the RV and the LV, and this is a really great look at that as well. All right, apical floor with an RV focus. Again, a really great one. Here you have an RV, and you can look for things like size, dilation, function, and hypertrophy. You can look for a dilated right atrium, left ventricular compression, etc. All right, we do have an order of preference in terms of like lesions that we like to use when determining the severity of pulmonary hypertension. The first is the PDA, then the VSD, then pulmonary insufficiency, tricuspid regurgitation, and finally septal flattening. Daniel Bernoulli and his simplified Bernoulli equation, which we're all familiar with. I just put this in the slide deck here because it's going to be the backbone for a lot of formulas you see throughout the presentation. Okay, tricuspid regurgitation. I'm actually going to start with this one just because it's the one that you guys are all probably most familiar with. You want to use the peak tricuspid regurgitation systolic Doppler velocity to determine right ventricular systolic pressure. Now, RVSP is going to be equivalent to systolic pulmonary artery pressure in normal anatomy, that is, no pulmonary stenosis. And down here you can see the formula we use. Scanning TR, there's a lot of great views for this, including apical floor chamber, RVIT, parasternal short, and apical REO. What you want to do is use little mini color sweeps to find the highest velocities. You want to keep your Doppler as parallel as possible to the flow. This is going to apply to all lesions. We all know that the more parallel your Doppler is to the flow, the higher velocities and more accurate they are. Then you want to capture the fullest CW Doppler envelope If it's not complete, try switching to a lower probe to complete that envelope, and then you want to use the highest velocity for your calculation. Okay, here's an example of some tricuspid regurgitation Doppler velocities. They happen to have a velocity of 5.1 meters a second, and if you run that through the equation, you're going to end up with a RVSP of 106 millimeters of mercury. Not great. Patent ductus arteriosus, one of the preferred ways of assessing pulmonary hypertension. However, PDAs tend to close in the first 12 to 24 hours of life. However, sometimes they will stay open longer than that. So when available, it's a great way to assess. So what you want to do is you want to use the PDA peak systolic Doppler velocity to determine systolic pulmonary arterial pressure. Systolic pulmonary arterial pressure is going to be the equivalent of RVSP in normal anatomy, i.e., say no pulmonary stenosis, and then large PDAs may equalize pulmonary and systemic pressures, making Doppler measurements unreliable. And here are some associated formulas. All right, scanning PDAs. We're going to start with the peristernal short axis. First thing you want to do is obtain a normal peristernal short base view with the indicator around 1 or 2 o'clock. Then to achieve the ductal or 3-finger view, let's count them 1, 2, 3. You want to move more superiorly towards the first intercostal space. You want to use small sweeps and rotation to find the widest diameter of the PDA by 2D and highest velocity by color Doppler. And then you want to adjust your Nyquist accordingly. Real quick on this, you may have to adjust your Nyquist scale up and down depending on the gradient between the right and left side. That is, under normal circumstances, it was a pretty decent gradient, so you're going to see a higher velocity, hence a higher Nyquist. However, as the pressures start to equalize or right pressures come up, then that gradient is going to be lower and thus a lower velocity, and therefore a lower Nyquist is needed to pick that up. Then what you want to do is perform full sweeps from before the aorta, past the pulmonary arteries, capture a 2D and color clips of the PDA. Then you want to drop a PW here for directionality, and oftentimes you'll have to use a CW for capturing the maximum velocity. All right, suprasternal notch. You want to place the probe in the suprasternal notch with the indicator around 1, then move towards the first left intercostal space. Again, you want to use small sweeps and rotation to find the widest diameter of the PDA by 2D and highest velocity by color. Adjust the Nyquist accordingly, like we just discussed. And then you want to perform full sweeps from before the aorta and past the pulmonary arteries. Capture 2D and color clips of the PDA. And again, you want to drop PW here for directionality and most likely CW for the highest velocity. Okay, PDA shunt direction. Left to right shunting indicates that systemic pressures are higher than pulmonary pressures, which is typically what you'll see. And the way you see that is the PDA will be seen as a red flow from the aorta up into the MPA. However, as you see in this video, you have right to left shunting, which indicates that pulmonary pressures are higher than systemic pressures, and that shows as a blue flow coming from the MPA down into the aorta. Now, a word of caution here, the blue PDA flow can oftentimes be confused for LPA flow. Here are some examples of PDA Doppler velocities. Over here on the left, we have a PDA with continuous left to right shunting in systole, 3 meters a second. It's going to equal 84 millimeters of mercury. A PDA with continuous right to left shunting in systole, again suprasystemic, is going to equal 136 millimeters of mercury. All right, VSDs. Here you want to use the highest VSD Doppler velocity to determine RVSP. Large VSDs may equalize RV and LV pressures, making Doppler measurements unreliable. And here are some equations related to that. Okay, scanning VSDs. Best views are going to include peristernal long, peristernal short, apicals, and subcostal coronal view. You want to use, again, long sweeps to find the widest diameter of the VSD by 2D and the highest velocity by color Doppler. Adjust your Nyquist accordingly. You want to capture color compare clips. You want to drop a PW right inside the VSD for directionality. Oftentimes you're going to need a CW to capture the highest velocity, and then you want to use the highest velocity that you capture to calculate the RVSP. Here's a couple Dopplers of VSD velocities. Again, on the left here, you have a VSD with left to right shunting in systole, meaning left-sided pressures are higher than the right. Has a velocity of 3.7 meters a second, which gives us a 65 millimeters of mercury RVSP. Over here, we have a VSD with right to left shunting and systole, meaning right-sided pressures are now higher than the left. And it's 1.5 meters a second. Run it through the equation, and you end up with 129 millimeters of mercury for RVSP. Suprasystemic, not so great. Pulmonary insufficiency. Okay, pulmonary insufficiency provides the best correlation to mean pulmonary arterial pressure measured by heart catheterization. Use the highest PI Doppler velocity at the beginning of diastole to determine mean pulmonary arterial pressure. And this is the related formula. Okay, scanning PI. The best views for PI include RVIT and parasternal short. Alternative views include apical RAO and subcostal coronal with an anterior tilt. You want to use small color compare sweeps to find the highest velocity, capture a full PI jet clip, and then use the CW Doppler to capture the highest PI velocity, again, at the beginning of diastole. Here are the two alternative views that I mentioned. The first is apical RAO. The way you achieve this is from apical 4. You want to rotate to approximately 1 o'clock and move a bit more medial on the chest and pan back and forth until you can see both the inflow and outflow. This is the RA, the tricuspid valve, the right ventricle, the RVOT, pulmonary valve, and MPA. And here you can see a pretty decent PI jet coming back at you. The other one is subcostal coronal with an anterior tilt, pretty far because the pulmonary artery is one of the more anterior structures of the heart. And of course, here you can see the MPA flow going out and the regurg coming back. Here's an example of some PI Doppler velocities. Over here, you have a velocity of 4.09 meters a second at the beginning of diastole. Run it through the equation, and we end up with 67 millimeters of mercury. Okay, septal flattening and the eccentricity index. EI is used to quantify septal flattening. It is a unitless measurement, and septal flattening can also be assessed without EI for a quick visual assessment of pulmonary hypertension. Okay, scanning septal flattening. Don't over-rotate. This is an important slide that I think you can all take a good nugget from. You want to start in parasternal short with a focus on the LV at the papillary level. The goal is to capture the LV at its roundest in end systole. You want to move higher on the chest, oftentimes more than you think you should, and then rotate the probe to achieve the roundest look. A low probe location and over-rotation can oftentimes make septal flattening appear more severe than it is. By example, here we have the exact same left ventricle, scanned just seconds apart. This one has proper probe location and proper rotation, showing mild septal flattening. This one has probe location that's too low and over-rotated, making it appear more moderate. Measuring septal flattening with the eccentricity index. I'm not going to go very far into this slide. However, if you'd like to learn more about this, you can always refer back to it. Here is an example of measuring septal flattening using the eccentricity index. You can see that we first measured parallel to the septum, then perpendicular to that. Running it through the formula, we get 2.1, which according to the chart, anything greater than 2 is severe. Visually, you can also see that the septum is beginning to bow into the LV. Okay, right ventricle, assessing the setting of pulmonary hypertension. Increased resistance in the lungs creates increased afterload, requiring the right ventricle to work harder to move blood. Increased afterload can result in hypertrophy, dilation, and reduced RV function. And of course, this can lead to right heart failure. Okay, scanning the right ventricle. Best views include apical 4 chamber, apical RAO, and subcostal coronal with an anterior tilt. A little tip on apical 4. If you want to get an RV focus, slide a bit more medial so that you can bring in the RV free wall right here. It's helpful to do a full apical 4 chamber sweep to get a more complete view of the RV. And of course, you can always go to apical RAO, which we previously discussed. All right, right ventricular hypertrophy. Increased global RV wall hypertrophy associated with increased afterload. Heart is adapting, this is what's going on here, the heart is adapting to maintain stroke volume against the afterload and is best assessed in diastole. And here are a couple examples of that. Right ventricular dilation. Dilation occurs after adapting via hypertrophy fails. What's happening here is the heart is attempting to maintain stroke volume by increasing the diastolic volume. And here's a couple examples of moderate dilation. Right ventricular function. So in the setting of increased afterload from pulmonary hypertension, the RV's myocardium will begin to fail. and this results in reduced RV function and cardiac output. And you can see here are two fairly severe examples of RV dysfunction. How to measure RV function using fractional area change. So this is very similar to the Simpson single plane measurement. It takes into account both longitudinal and radial function, i.e. tap, see, and squeeze. It can be measured in an RV-focused apical floor chamber. You measure the end diastolic area, then the end systolic area. Don't include the tribeculations. And going off of this example here, we run it through the equation, and you can see that this patient has an FAC of 24.6%, which makes it moderately diminished. Anything above 35% is considered normal. Okay, when should you immediately contact a physician? Anytime you see a TR jet of greater than 4 meters a second, a PDA with right to left shunting and systole, pulmonary insufficiency greater than 3 meters a second in the beginning of diastole, severe septal flattening, or RV function reduced from prior echo. Now, my suggestion to you is if the kid is stable, continue to build your case about the pulmonary hypertension and then reach out to your attending. However, if you have immediate concerns about the child and you see any of these indicators, then I would immediately reach out to them. Here are my references. And that will conclude my presentation on pediatric pulmonary hypertension. If you do have any questions, there's going to be a Q&A at the end of this presentation set. Additionally, if you'd like to follow up with me for further questions, you can always reach me at my email below. Thank you very much and have a great day.